Hello, my name is Delo, and today we are going to do a competency for intubation. So first we are going to evaluate the indications for this procedure. So some indications could be severe sedation, drug overdose, severe hypoxemia, or respiratory distress, and it could be also for patient having a surgery. So after that, we are going to check the patient's chart. We are looking for the chief complaint of the patient, vital signs, current oxygenation of the patient, um, patient's history, if the patient was previously intubated, what size of tube did they use, is it an easy intubation or hard, how many times did it take, if they failed the extubation, or how was the weaning process, is it hard or not. Next, we are going to gather all of our equipment. We have a laryngoscope. We need to make sure that the light source is working. And then we also need to have two kinds of plates. We need to have a male and we need to have a Mac. So a male is directly displacing the tongue or epiglottis, and then the Mac is indirectly displacing the tongue or the epiglottis via the vallecula. Next, we need to have a stylet for guidance. We need to have two kinds of or two sizes of ET tube. We need to have the actual size that the patient is using. So we are using an 8 for this procedure, and we need to have a size smaller. So for women, the sizes ranges from 7.5 to 8, and then for males it's 8 to 9, but normal for everybody is an 8. We need to have an oropharyngeal and an nasopharyngeal. We need to have a manometer, or we could do a minimal leak or occlusion. We need to have our gauzes if we're using a securing device such as tie. And then we also could use a tape. We need to have a lubricant, HME, and an inline section. We need to have our gloves. We need to have our syringe to inflate the pilot balloon, a bite block, a capnograph, a marginal forceps. We can also have a towel for the sniffing position if we need to, a bougie to help, and an exchanger just in case. Our stethoscope, we need to have our other section, consists of Yonker. So for this vacuum, we need to have a pressure of at least 120. Could range to 100 to 120 or 120 to 150 depending on the source that you're using. And then we need to have an ambu bag with a PEEP valve and an appropriate size mask. We need to also check the manual resuscitators feature. So we could check the duckbills, occlude it and press, or completely deflate it and press, and if it goes back, it means it's ready to go. We also need to hook this up in an oxygen source. Make sure that it's on 100 so we could hyperoxygenate the patient before doing the actual intubation. And then at this point we could also check the ET tube. So we will inflate the pilot balloon and see if the balloon inside is gonna hold the pressure, and it is. So we could use this, deflate it, and then at this point we could also lubricate it. Open this side. That way when we lubricate it, the entire tube will not be lubricated because it's going to be harder for the physician or for the RTs to hold it. So after that, after all of the checks and having all of our equipment done and ready to go, we are going to the patient's room. So I'm going to wash my hands and then going to inside the patient's room and introduce myself, and then get the patient's identifier. So, hello, my name is Delo. I am from the respiratory department, and can I get your name and date of birth? And then after they state their name and date of birth, you need to look at their wristband to just to confirm. And then after that, we are going to um, we are going after that we are going to ask the patient, tell the patient what the intubation or the procedure is for, what's it gonna do, risks and safety precautions that we could do. So, hi sir, we are going to do an intubation procedure in you. So an intubation is basically inserting a breathing tube in your windpipe or your airway, so that when you're in your procedure of having a surgery, we are breathing for you, because you are going to be in complete sedation and it could knock out your respiratory drive or your breathing drive. So some risk on this procedure is we could chip your tooth or knock your tooth out if you are not completely sedated. You could cough, we could irritate your stomach and you could vomit. We could also create some traumas in your airway. So I need to make sure that you understand that, okay? And some safety precautions that we could do is that we will make sure that we will do our best to avoid all of those risks, and then we are going to make sure that you are well taken care of. Is there any questions with this procedure? And if the patient or if there's any family member says that there's none and they understand what the procedure is, then we could go ahead and start the procedure. So at this point, I'm going to glove up and I'm going to call my assistant Brian to assist me with getting my equipment set up. So at this point, the patient is already sedated. My assistant will be pre-oxygenating the patient so that we will be ready for the procedure. So this procedure, I'm using a male because I'm more comfortable with a long blade rather than the small one and curved. Okay, so right now our patient is being oxygenated. So doing any kinds of procedure, we need to always monitor, the vital signs, and because that's how we're going to determine how the patient is doing. And then, so doing this procedure, the intubation, we can only go for a maximum of 30 seconds, and after that we need to pre-oxygenate the patient again. Okay, so right now I'm looking at my clock. I'm starting at 6, so in 3, 2, 1, go. Can you hold the head for me, please? Tube. Okay, it's in. Capnometer, please. Thank you. So right now, I'm going to bag and hold it. Can you listen to the lungs for me, please? Thank you. Okay, so right now he's listening to the stomach to see if it's in the stomach. Listening to the lungs, see if there's a bilateral lung sounds. Then seeing if there's any chest rise. Are we good?
Good.
Okay, we're good. So at this point, I'm going to ask my assistant to hold the tube and bag for me. Thank you. So once we're already good with the ET tube, everything is set. We are going to secure the tube. using a tie. So can you lift your hand up? Thank you. Sure that this is not on the way. We'll also want to make sure that this is close together. Just do a shimmy to tighten it up. Okay. Also want to look at the teeth. So at the teeth, we are on 22. Securing it. Make sure that we don't tie it tightly, and we don't tie with the pilot balloon on the way. Okay. This is where we want it to tie really tight so that the ET tube won't get dislocated. See, so it's really tight. At least 2 fingers could go in there. Then we are going to put the gauze in to prevent breakdown of the skin. Okay, so I'm also going to check again if it moved. So we're still on 22, so we're good. Didn't move. And then next up is we could use a bite block to prevent kinking of the tube or patient from biting it. So after that, we are also going to change the capnometer or the capnograph to the inline. So take it out for me. Thank you. So we could connect the this HME and the inline to a mechanical ventilator, or still use a manual resuscitator. So at this point, we need to check our cuff. So we could use a manometer or a minimal occlusion or minimal leak. Okay, so it's in right now it's in 25. So the normal is 25 to 35 for the cuff pressure. And then after that, we could also check if there's any condensation in the tube. So that means that there's CO2 going out. And then this will also turn yellow, just in case for earlier, if there's any CO2. So that will determine or let you know that you're in the lungs because there's a response. So after that, now that that's connected in there, we could do the follow-up. So we need to order an X-ray just to make sure that the placing of the tube in the lungs, so it should be at least 3 to 5 centimeters above the carina. And next, we check the cuff pressure, so it's 25 to 35. It should be in there. And then we could do it by a manometer, minimal occlusion or minimal leak. And then we would also obtain like the vital signs such as the lung sounds and check the capnograph if there's a CO2 response, which is it'll turn yellow. And then we need to look at the humidity level, so that's why we have the HME, and then the condensation will also let us know about that. And then if there's any suction needs to be done, so if the patient is salivating, which usually happens, so we could suction it using younger, or if the patient needs to be suctioned inside lungs, we could use an inline. Then after that, we need to provide like some kind of patient communication, so such as a whiteboard, so that when a patient wakes up, the patient could communicate with the healthcare provider. Then after that, we could clean up. We could clean up all of the equipment that we've used. We could send the laryngoscope, the blade, or the stylet into the cleaning, or if it's disposable, then we could just toss it. And then after that, I'm going to wash my hands. So toss this, and then I'm going to wash my hands. And after that, I'm going to report or chart all of my findings. So I'm going to, again, glove up in this case, so I could look if it moved while doing the other procedures, such as, you know, connecting it into the inline. So it's still on 22, so we're good. So I would chart how many times did it take for me to intubate. Was it easy? Was it hard? What size of tube did I use? If it's like what length it is. So right now it's 22, so I would document 22. I would document vital signs, the mechanical ventilation level, so such as the PEEP level of the patient, and then I would also document like who's in the room, because that's always kind of helpful for that. And then after that, we are good to go, because the patient is already ready for the surgery. So some follow-up questions is, as I said earlier, male is directly displacing the tongue or the epiglottis, and then the MAC is indirectly displacing the tongue or the epiglottis via the vallecula. And then difference between blind and visual nasopharyngeal intubation is blind is we're blindly inserting tube inside the patient's nose, and then once we see the tube in the mouth, we could advance it using a marginal forceps. And a visual is using a bronchoscope with a camera. And then the maximum time that we could do an intubation, as I said earlier, is 30 seconds. And the position of the ET tube should be at least 3 to 5 centimeters above the carina. Some complications in this procedure could be for a prolonged tracheal intubation or endotracheal, is that the patient could be desatting. So that's it. Thank you.